Bismillahirrahmanirrahim. Today we are going to discuss the section 2 of developmental abnormalities in bone cell matrix and structure. Last week we have covered the section 1 of this lecture. Following are the references. The learning objective for today's lectures are almost same as the previous one. We have covered the learning objective 1 and 2 almost completely. That is, describe the different form of bone cell and bone matrix, and also explain the bone modeling and remodeling process. To some extent, we have also discussed the pathogenesis of bone disorders, and today we are going to continue these pathogenesis. By the end of this lecture, you will be able to interpret following clinical scenarios. So we have seen the classification of developmental abnormalities in bone cell matrix and structure, and we have broadly described the malformation and diseases caused by defect in nuclear protein and transcriptional factor. Then diseases caused by defect in hormone and signal transduction mechanisms, disease associated with defects in extracellular structural proteins, and we will discussed various collagen disorders under this head. And the most common one of this was osteogenesis imperfecta. Then there were diseases which were associated with the folding and degradation of macromolecule defect, and the important member of that head was mucopolysaccharidosis. Then the diseases associated with metabolic pathways, enzymes, ion channels, and transporters, and the important member of that group was osteoporosis, and we discussed various autosomal dominant and autosomal recessive, and one X-linked this osteoporosis also. Then disease associated with bone mass, osteoclast dysfunction, and abnormal mineral homeostasis we will cover today. So this was the way to develop a schema to segregate and divide various disorders of the bone under various heads according to their pathogenesis. But when we go to the literature, we will see another term, that is metabolic bone disease. Metabolic bone disease is a term which encompasses all the defects of bone synthesis, destruction, or reduced bone mineralization individually or in combination that result in structural defect in the skeleton, and these are secondary to some sort of metabolism. Okay, so all these disorders are termed as metabolic bone diseases. So in this picture you will see you can see a normal bone in which this lamellar bony trabeculae are of normal thickness, and the osteocytes are evenly distributed, and in the center you can see a lot of dispersed fat globules also there, and a blood vessel in the center also. So when we discuss about diseases associated with decreased bone mass, there are two terms. One is osteopenia and another is osteoporosis. The osteopenia is simply decreased bone mass, while the osteoporosis is the osteopenia that is severe enough to cause a fracture or increase the risk of fracture. The extent of bone loss is very important, because in osteopenia the decrease in bone mass is only between 1:2.5 standard deviation from that of normal, and in osteoporosis this bone mass is significant, and it is at least 2.5 standard deviation below mean for a year. Okay, so extent of bone loss is important parameter. So now you can say that the osteoporosis is a metabolic bone disease in which the bone is normally mineralized. So it is not defect of mineralization bone, it is basically decrease in bone mass, and due to decrease in more bone mass, the bone is soft enough that it cannot provide you mechanical or structural stability. So to categorize the osteoporosis, you can categorize it into localized and generalized varieties. Localized example is diffuse osteoporosis of a limb, and generalized is one of the manifestation of the metabolic bone disease, and these can be primary or secondary. So coming to epidemiology of the osteoporosis, the post-menopausal and senile osteoporosis are commonest, and these are generalized varieties, and most common fractures encountered in the osteoporosis are fractures of hip, and the common area is neck and intertrochanteric region of the femur, then vertebral bodies and distal radius, and the distal radius fracture is also termed as Cooley's fracture. Whites are frequently more commonly affected than that of black. Female is to male ratio is 2:1 for hip joint, and it increases to 8:1 for vertebral body fracture. This male-female preponderance or distinction nullified in Asians and blacks, in which it is both genders are equally affected. 1 million individuals in USA are affected each year by this osteoporosis, and this 1 million patients are about 14 billion US dollars health burden on health budget of the USA. About 40 to 50,000 of these osteoporotic patients develop the fracture. Looking at these figures in USA, we can conclude that in our part of the world, this disease must be on higher side because of dietary problems and nutritional disorders. Osteoporosis can be divided into primary or secondary. Primary osteoporosis is more common variety and is of uncertain in origin, and principally it occurs in postmenopausal women and elderly people. When it occurs in postmenopausal women, it is termed as type 1, and when it occurs in elderly people, it is termed as type 2 osteoporosis. Secondary osteoporosis we label it as secondary when it is associated with a defined etiology. So this type 1 osteoporosis, that is postmenopausal, is associated with an increased osteoclastic activity, hence number of remodeling sites in the body are increased. This phenomenon is termed as increased activation frequency. So detail of this the pathogenesis of these disease we will see in upcoming slides. And what happens in type 2? Type 2 is in fact the result of osteoblastic functional insufficiency. Here the osteoclasts are functional normally, but osteoblasts lag in synchronizing with their partner. So it is basically the osteoblastic incapability to cope up with the resorption which is done by the osteoclast. So we have seen that this secondary osteoporosis is the result of extra-osseous disorder, and there are many categories: endocrine disorder, neoplasia, gastrointestinal disorders, certain drugs, and miscellaneous causes. And when we talk about endocrine disorder, the hyperparathyroidism, hypothyroidism, pituitary tumor, diabetes, and Addison's disease, all these are associated with osteoporosis. What happens in hyperparathyroidism? Hyperparathyroidism induces osteoclast recruitment and its activity, while hyperthyroidism increases osteoclast activity and bone turnover. It is, however, associated with a limited bone loss. In hypogonadism, if in female it is due to loss of estrogen, and in men it is due to deficiency of anabolic androgens. Osteoporosis is frequently seen in individuals who have been receiving anti-androgenic therapy for the prostatic carcinoma. Then neoplasia, various neoplasia are also associated with osteoporosis such as multiple myeloma. What happens in multiple myeloma? The plasma cells are abnormal or malignant. These malignant plasma cells, they secrete osteoclast activating factor, and these osteoclast activating factor in fact then is responsible for the damage. Osteoporosis is also seen in various leukemias and lymphomas also. It is one of the manifestation of the squamous cell carcinoma of the lung, in which if there is no metastasis of the bone, but there is evidence of osteoporosis, and this is attributed to parathyroid hormone related peptide. For gastrointestinal disease and hepatic disease, both these diseases result in impaired resorption of calcium, phosphate, and vitamin D. And as you know, these are the important constituents for the bone homeostasis. Hence, it leads to osteoporosis. Then there are certain drugs which are associated with osteoporosis. One is anticoagulant, and some of the anticoagulant, as you know, calcium is one of the factor of coagulation. Some of these anticoagulants are inhibitors of the calcium, and hence they lead to this osteoporosis. Then corticosteroids is the most common form of iatrogenic osteoporosis. And what happens in corticosteroid administration? It inhibits osteoblastic activity. So after the inhibition of the osteoblastic activity, there is disturbed bone formation, and these corticosteroids also impair intestinal absorption of the calcium, and hence there is increased secretion of parathyroid hormone, which leads to increased osteoclastic activity. Alcohol is direct inhibitor of osteoblast, and it also impairs absorption. So we have seen this slide in previous lecture also, and this peak bone mass is basically the amount of bony tissue that is present at the end of skeletal maturation. It is determined by a lot of factors such as diet, age, exercise, physical activity, muscle strength, nutritional or hormonal status. Then there is polymorphism in the receptor for vitamin D, and low density lipoprotein related protein 5 or 6, and once it is attained after the fourth decade of the life, there is about 0.7% decrement per year, because the osteoclastic activity slightly exceeds than that of osteoblastic activity. So in the upper part you can see that peak bone mass is determined by a variety of factors. Age related and postmenopausal are important one. Reduced physical activity result in osteoporosis, as we have seen earlier, the concept of mechanotransduction. This mechanotransduction is responsible for the bone formation. It is also true for astronauts who develop osteoporosis due to loss of gravitational forces. Hence, biological translation of mechanical forces is impaired. Effect of load magnitude is more, hence weight training exercises increases bone mass significantly than endurance training such as bicycling, in which there is repetition of load. Aging is another cause of this osteoporosis. As men get older, their physical activity and movement became limited, hence it's another contributing factor for the development of osteoporosis. There is another mechanism that these osteoprogenitor cell osteoblasts, they have got decreased replicative or synthetic activity, hence their biological activity of matrix bound growth factor is reduced. There is a complex mechanism of bone homeostasis regulated by rank ligand, OPG, that osteoprotegrin, estrogen receptor, vitamin D receptor variant, low density lipoprotein related protein 5, and many other factors, any mutation in in the genes of these can lead to increased osteoclastic activity, hence osteoporosis. The nutritional factor or the nutritional status contribute to the factors that determine peak bone mass. As we have seen in the cause of the osteoporosis, that the gastrointestinal and liver diseases may result in osteoporosis due to impaired calcium absorption. In the estrogen-influenced osteoporosis, what happens in a decade after menopause, 2% of the cortical and 9% of the cancellous bone are lost each year. And due to this, about 40% of postmenopausal women suffer from osteoporosis. Decreased estrogen concentration, it leads to increased secretion of interleukin 1, interleukin 6 and TNF and through mysterious mechanisms, and this result in decreased osteoporotocrin and rank ligand. Both of these are decreased and hence osteoclasts are invited and stimulated. So osteoporosis is decreased bone amount, but it is normal. In both these postmenopausal and senile osteoporosis, the process is generalized. What happens in postmenopausal osteoporosis, the most affected bones are the bones which have got increased surface area, such as the cancellous compartment of vertebral body. The trabecular plate of these vertebral body become perforated, thinned and lose their interconnection, microfracture occur and vertebral collapse as a result. In senile osteoporosis, there is widening of the Haversian system with thinning of the cortex as a result of subperiosteal and endosteal resorption. In severe cases, there is cortex looks like a cancellous bone, and the bone that is there, it is normal in composition, though there are gaps, the discontinuity or gaps in the trabeculae, but bone is of normal composition. The senile osteoporosis shows decreased trabecular thickness, and postmenopausal osteoporosis display discontinuity between trabeculae, and this discontinuity is due to working osteoclasts, which lead to perforation of the trabeculae and ultimately the fracture. And in histology, this loss of continuity or connectivity of the trabeculae gives the appearance of isolated bone island in histology. In the upper picture, you can see that there is compression fracture of the vertebral body. So this is a picture from characteristic loss of horizontal trabeculae, while the vertical trabeculae are thickened. Neck of the femur, a normal section of the neck of the femur is compared to that of osteoporotic. You can see the extreme right one on the upper picture, that it is very much spongiotic, very much decreased intensity than that of the normal one, which was cut to the same thickness. And in the lower picture, you can see that there is loss of connection in the bony trabeculae, and these trabeculae are decreased in number, and also there is loss of connection, they are decreased in number and decrease in size also. So histologically, this osteoporosis can be active or inactive type. What happens in active osteoporosis? There is increased bone resorption and formation. That means the turnover is increased. The osteoclast, osteoblast both are increased, and the width of the osteoid seam is normal. In inactive osteoporosis, what happens? The bone formation is minimal and reduced. Resorption of the bone by osteoclast. This is a low turnover osteoporosis. Osteoid is decreased and increased width of osteoid seam. So these are the basic differences in the active and inactive osteoporosis, which are histologic categories of this osteoporosis. So as the lesion advances, both the cortical and trabecular bones are affected, and they are very much thinned. As far as the clinical features are concerned, the clinical features are dependent on the bone which is involved, and these include vertebral fractures, thoracic and lumbar region fractures. These are painful, loss of height, various deformities such as the lumbar lordosis, scoliosis, kyphoscoliosis, etc. When there is fracture of the femoral neck, pelvis or spine, one of the complications of the fracture is pulmonary embolism and pneumonia, and it is responsible for about 40 to 50,000 deaths per year in USA. Plain radiographs for the diagnosis of osteoporosis are not useful because cannot reliably detect until significant bone loss up to 30 to 40% has already been there. Then biopsy of the bone is rarely performed these days. DEXA, that is dual energy X-ray absorptiometry, and quantitative computed tomography, both of these tests they measure bone density, hence these are useful in the diagnosis of osteoporosis. So how do we manage the osteoporosis? We correct the various factors which are responsible, which are the active players in the bone homeostasis. We correct these through exercise. We increase the calcium intake, and vitamin D facilitated calcium absorption. So we give the supplements. Along with this, we also give bisphosphonate, which reduces osteoclastic activity and induce osteoclastic apoptosis. So note that all these bisphosphonate or some of the other antibodies, such as these denosumab, which is anti-REC-ligand antibody, it also prevent the action or activation of osteoclast. All these they have action on the osteoclast. None so far has proven their effect on the activation of osteoblast or bone formation. So for the management, we have to consider, we have to give the supplements also. Then hormone replacement therapy, especially in postmenopausal variety of osteoporosis, that is type 1 osteoporosis. It was also advocated previously, but it has got some complications, associated complications, that are DVT and stroke, so it is not usually advocated. Now coming to the diseases caused by osteoclast dysfunction, an important disease of this group is Paget's disease, which is also termed as osteitis deformans, and it's a disease which is marked by increased disorder but structurally unsound bone mass. This abnormal formation of the bone tissue, it results in weakened and deformed. Though there is increase in the bone mass in total, but as the bone is not forming properly, it is deposited irregularly and not in normal fashion, so it is not going to serve one of its basic function, that is structural support, and it is going to be a deformed bone. There are three phases of this Paget disease. One is an initial osteolytic stage, in which there is osteoclastic activity as a result of loss of the bone. As both osteoblast and osteoclast they work together, what happens in stage 2, there is, due to imbalance, there is imbalance among these two cells, osteoclast and osteoblast, and due to imbalance there will be lacking of mineralization, which will lead to the development of jigsaw puzzle or mosaic pattern histologically in the affected area. If you recall your concept of healing from the general pathology, these narrowed spaces, they are filled with collagen now, and as you know, the collagen is less vascular, so these areas will be less vascularized and filled with collagen. The third stage is also termed as quiescent stage, burnt out stage, or osteosclerotic stage, and it comes years after the initiation of the pathologic process, and due to excessive useless bone formation, it is more compact and it is more dense. This third one, on radiology, this third one is the burnt out stage is also appears as cotton wool appearance. We are going to see some of the X-rays of Paget disease also in the upcoming slides. So the characteristics of the Paget disease are that it is a disease of osteoclast, which are abnormal, increase in number, and this can occur in focal areas of bone, and it can be monostotic also. 1% of the population in the US who have crossed 40 years of age are affected by this disease. The average age for disease onset is about 70 years. 1/3 of the people of these patients are above the age of 50, and this disease is manifested in about 10% of the people over the age of 80 years. It is more common in whites. It's a disease of white, and it is more common in England, France, Austria, Germany, Australia, and New Zealand, and rare in the native population of the Asia, China, Japan, and Scandinavian countries. For UK, its prevalence is 2.5 for men, and for female, it's 1.6% in population of 55 years or more. The incidence and severity of this disease has been decreased in last 25 to 30 years in various areas. Now, etiology of the Paget disease, it was very much mysterious since Paget identified this disease in 1887, and he labeled it as inflammatory. Then some scientists considered that this has got a viral etiology. Some considered that it is a vascular lesion. Then some considered this as neoplastic lesion. It was attributed to lead toxicity in late 1990s. Then in 1996, some considered that there could be genetic origin. The current theory of the etiology of this Paget disease is the genetic factor and non-genetic factor. It is thought that both these work together, and both these factors, genetic and non-genetic and environmental factors, are responsible for the initiation of the disease. So regarding genetic factors, 7 potential susceptible loci have been identified for the Paget disease of the bone. SQSTM1 gene is the most important one for the development of adult Paget disease of the bone. This is the sequestrosome 1 gene, and 15 to 40% of the patient with this disease have at least one affected first degree relative. 25 to 50% of familial cases and 5 to 15% of the sporadic cases, they show this characteristic mutation, that is sequestrosome 1 gene mutation. What happens? This sequestrosome 1 gene is involved in the activation of rank, and hence subsequent activation of nuclear factor kappa B. So it leads to increased osteoblastic activity and increased susceptibility to the disease. There are some variant, juvenile Paget disease of the bone. It is the result of activating rank mutation or inactivating osteoprotein mutation. Now the non-genetic factors are thought to play their role because the disease show variable penetrance. It is localized to a bone or part of the bone, and incidence and severity of the disease changes. It is also thought that viruses play some role in the etiology of the aged disease of the bone, and the clue to this etiological process came from the presence of viral nuclear protein which were present in the within the nuclei of the osteoclast. So Paget disease is a disease due to abnormal osteoclast, and as we know that the osteoclast in the current theory of the Paget disease are affected by viral inclusions or by genetic mutation. So when an osteoclast is mutated or has got incorporated virus in it, it is transformed into a giant osteoclast, which has got different morphology. It is now a multinuclear. Normally, we know that there are 6 to 12 nuclei in the osteoclast, but in this osteitis deformans, these nuclei can go up to 100. And obviously, this viral inclusions are also seen in the DNA, as we have discussed earlier. This giant osteoclast then releases various osteoclastic factors, and there are some osteoblastic recruitment factor, while some are matrix factor. The matrix factors are responsible for angiogenesis and fibrosis, while the osteoblastic uh, recruitment factors, they recruit more osteoblasts to that milieu, and due to presence of more osteoblasts, now they activate further osteoclastogenesis, and hence the circle continues. So osteoclast in Paget's disease have got distinct morphology as well as distinct physiology, uh, as we have discussed many times earlier, that they are characterized by the presence of viral inclusions within the nuclei, which is evident by electron microscopy, as you can see over here in the left diagram. And also these are physiologically very much hypersensitive to osteoclastogenic factor such as vitamin D and rank ligand. As the disease is characterized by various stages, so there is variation in the histology of this Paget disease over time and across the site. The hallmark for osteosclerotic phase is mosaic pattern, which is also termed as jigsaw puzzle-like appearance. And while other phases they have less specific features. That includes osteoclastic activity, and there is presence of resorption pit in the lytic phase. The characteristic morphology of the osteoclast we have discussed many times earlier. So first there is replacement of marrow adjacent to the bone forming surface by loose connective tissue having osteoprogenitor cells and numerous blood vessels. First vivid bone is formed, which is ultimately replaced by lamellar bone. As the mosaic pattern predominates, the cellular activity is diminished and periosseous fibrovascular tissue moves back and normal marrow restores. Finally, their result is coarse, thickened trabeculae and soft porous cortices. These are caricature of the normal bone, and this caricature of the normal bone lacks structural support and hence at risk of fracture. This is a gross specimen of a femur, and the cut section of a femur, where you can see in the lower arrow there is a cortical thickening, and the upper there is coarse trabeculation. These trabeculae, as you know, are derived from the Latin word trab, and it means beam or bar. So these thickened trabeculae or bars or beams are not going to provide structural support to the bone due to the various morphological defects we have seen earlier. As far as the clinical features are concerned, the clinical features are dependent on the bone which is involved, and these include vertebral fractures, thoracic and lumbar region fractures. These are painful, loss of height, various deformities such as the lumbar lordosis, scoliosis, kyphoscoliosis, etc. When there is fracture of the femoral neck, pelvis or spine, one of the complications of the fracture is pulmonary embolism and pneumonia, and it is responsible for about 40 to 50,000 deaths per year in USA. In the X-ray on your left side, you can see that there is dissolution of the cortex, and the diaphysis is increased in diameter. Also, there is a wedge-shaped resorption of the cortex, and this resorption of the cortex is forming a flame-like structure within it, and this is termed as flame sign. And this flame sign is the characteristic of early Paget disease. As the disease advances, uh, it is characterized by radiologically by the cotton wool appearance, that is the presence of cortical disorganization and irregular coarse trabeculation. So cotton wool appearance is the characteristic of late Paget disease. This X-ray is showing the characteristic picture frame appearance of the lumbar vertebral body, and this is due to thickening of the cortices and end plates. So first there is replacement of marrow adjacent to the bone forming surface by loose connective tissue having osteoprogenitor cells and numerous blood vessels. First vivid bone is formed, which is ultimately replaced by lamellar bone. As the mosaic pattern predominates, the cellular activity is diminished and periosseous fibrovascular tissue moves back and normal marrow restored. Biochemical markers are available for the diagnosis of Paget disease. Some are markers of bone resorption and some are markers of the bone formation. Though there is marked elevation of the serum alkaline phosphatase, but serum calcium and serum phosphate are within normal limits. If there is no malignant transformation, the disease, the Paget disease, is not a life-threatening condition, and mostly the individuals which have been affected by this disease and having mild symptoms are treated by calcitonin and bisphosphonate, which decreases the bone turnover. Gaucher disease also shows some of the skeletal manifestation. It is basically accumulation of glucosylceramide, mainly in the macrophage lysosomes, and this is the autosomal recessive disorder. Uh, uh, the beta-glucosidase genes is located on chromosome number 1, long arm. The gene product is glucocerebrosidase enzyme. When due to mutation in the gene, single base mutation, this enzyme is defective, and as a result, the substrate, that is glucosylceramide, is accumulated within the macrophage cells or reticuloendothelial cells or any cell in the body. Uh, this is accumulated within the cell, and this glucosylceramide is basically derived from the senescent leukocytes all over from the body, and in the brain these come from the cell membrane gangliosides of the cells in the C. Histologically, the characteristic appearance of this Gaucher cell is that the cells are very much enlarged, the nucleus is pushed towards one side, and the cell cytoplasm shows PAS positive, polyperiodic acid shift reagent positive material, which shows characteristic crumpled tissue paper appearance. Besides its many manifestations, the Gaucher disease is associated with different skeletal manifestation. One of these skeletal manifestation is failure of remodeling, which is most common, and it is the least problematic when compared with other systemic manifestation of the disease. Absent flaring and abnormal funnelization and centralization are present, which are necessary for bone remodeling and modeling, therefore lead to Erlenmeyer-Flask deformity of the proximal tibia and distal femur. The bone crisis is rare and result from acute infarction of the large bone segment due to interruption of the blood flow by the Gaucher cell. Then localized and diffuse blood loss remain asymptomatic unless fracture occur. Then another manifestation is osteosclerotic lesion, which is usually seen in the medullary cavity. Corticomedullary osteonecrosis usually affect proximal humerus and head of the femur and is a result of compromised blood supply. Pathological fracture, as we have seen, disturbed metabolism with thinning of the cortex, osteolysis and osteosclerosis, etc. It may lead to spontaneous fracture of the vertebrae, long bones or pelvis. Then osteomyelitis and septic arthritis are caused by hematogenous spread of coliform and anaerobic organism, usually after surgery. Now coming to the diseases associated with abnormal mineral homeostasis, there are two entities that are rickets and osteomalacia. Both are characterized by the reduction in bone mineralization. Rickets is a disorder in children in which there is derangement of the bone growth plate and it produces characteristic abnormalities. Then osteomalacia is an adult in which the bone that is formed during the remodeling process is not properly mineralized. The basic mechanism for the pathogenesis of these diseases are abnormalities in vitamin D, the metabolism, phosphate deficiency state, or defects in mineralization. Nutritional causes: GI absorptive defect, renal tubular defect, renal osteodystrophy are the major causes of abnormal mineral homeostasis, which leads to rickets and osteomalacia. So serum calcium and serum phosphate are the two important members which are responsible for the normal bone homeostasis. 99% of the body calcium is in the bone, and its main function is the muscle and nerve function, and it is also a member of the clotting factors. Then 50% of the plasma calcium it is in bound state, and 50% is in free state. Dietary needs are various according to phases of their life. It is maximum during the breastfeeding, that is 2 gram per day. This calcium is absorbed in the duodenum, where it is absorbed by the active transport, and in the jejunum by the diffusion. And 98% of this calcium is reabsorbed in the proximal kidney tubules, and this can be excreted in the stool. Phosphate: 85% of the phosphate of the body is in the bone. As you know, it is a metabolite. It is important mineral for the production of the energy, and it is also a buffer in various enzyme systems. It is present in the plasma in unbound state, and daily requirement is about 1 to 1.5 gram per day. So the regulation of the calcium and phosphate in the body is through the interplay of parathyroid hormone, vitamin D3, calcitonin, and beside these three major characters, there are other hormones also, such as estrogen, corticosteroid, thyroid hormone, growth hormones, and various growth factors are also there, which are responsible for the bone homeostasis. This picture is showing the interplay by major regulatory factors of the calcium and phosphate. Metabolism: the calcium is absorbed from the intestine along with and phosphate is also absorbed from the intestine, and the calcium absorption is by the stimulated by the vitamin D. Then this calcium and phosphate reaches into the extracellular space. The sensor in the body for the calcium alteration concentration change are located in the parathyroid gland, and this parathyroid gland secretes parathormone, and this parathormone, when calcium concentration is decreased in the body, it releases calcium from the bone, and as you know that the calcitonin receptors are present on the osteoclast, and when the thyroid gland secretes thyroid hormone, it causes the decrease of calcium release by suppression of the osteoclast. Vitamin D also releases calcium from the bone, and this release is regulated through the parathormone, as the parathormone also regulates the concentration of alpha-1 hydroxylase, which is responsible for the conversion of the 25-hydroxycholecalciferol to the 1,2,5-dihydroxycalciferol in the body, and there is this parathormone also stimulates absorption. This parathormone regulated vitamin D also stimulates absorption of the calcium from the intestine. Also, this parathormone increases the resorption of calcium and decrease the resorption of phosphate from the kidney tube. The regulation of the production of vitamin D in the kidney is by three mechanisms. When there is hypocalcemia, the parathyroid hormone release parathormone, and it is responsible for increase in alpha-1 hydroxylase activity within the kidney tubule. and due to this activity the 25-hydroxy vitamin D is converted into 1,2,5-dihydroxy vitamin D. And if there is hypophosphatemia, this is the another mechanism, and there is hypophosphatemia, it also increases the activity of alpha 1 or expression of the alpha 1 hydroxylase, which is responsible for the conversion. Then if the conversion is enough, it is uh, it is going to inhibit the release of alpha 1 hydroxylase, and so the conversion is stopped, and the alpha 1 hydroxylase concentration is also decreased. Vitamin D is a contributor of mineralization of the osteoid matrix and epiphyseal cartilage through stimulation of production of osteocalcin by the osteoblast. As we have studied in lecture 1, that there are two types of ossifications. One is intramembranous and another one is enchondral. In intramembranous ossification, mesenchymal cell directly differentiate into osteoblast and then mineralize, while in enchondral ossification, the growing cartilage at growth plates provisionally mineralized, resorbed, and then replaced by osteoid matrix and forming bone. In vitamin D deficiency states, the substrate for alpha 1 hydroxylase is decreased, hence the vitamin D concentration in blood is also less, and there the facilitatory role of the vitamin D for the absorption of calcium and phosphate from the intestine is reduced. This led to the decreased serum calcium and phosphate concentration, and this decrease in serum calcium and phosphate concentration is sensed by parathyroid, which releases parathyroid hormone, and as a result of increased concentration of the parathormone, there is mobilization of calcium and phosphate on one hand, and on the other hand the parathormone increases the wastage of phosphate from the kidney tubules. Both these effects result in decreased product of calcium and phosphate, which leads to poor mineralization of the bone. So there in the normal costochondral junction, there is formation of cartilage palisades and orderly transition of the cartilage to the new bone, as we have seen earlier. What happens in rickets? There is inadequate provisional calcification, failure of the chondrocytes, maturation, and apoptosis, which results in overgrowth of the epiphyseal cartilage. These overgrown masses then project into the marrow. The osteoid matrix is deposited on poorly mineralized cartilage remnant. The orderly replacement of the cartilage is disrupted by the deposited matrix and result in expansion of osteochondral junction. Inadequate weak bone is hence formed, which undergoes repeated stress and fracture, leading to capillary and fibroblast overgrowth. All these factors contribute to the bone deformity. The clinical feature of these rickets, they are dependent on the stage of the infancy. For the non-ambulatory stage of the infancy, head and chest are affected usually, and there is softening of the bone, frontal bossing or square-shaped appearance of the head, or chest is characterized by rachetectomy and pigeon breast deformity. In ambulatory stage, lumbar lordosis and bowing of the legs are noted. This picture is showing the bowing of the legs due to formation of poorly mineralized bone. This picture is showing the bowing of the legs due to formation of poorly mineralized bone. And here on all the clinical features. Here this illustration. Thickening and widening of the physis, that is growth plate, cupping of the metaphysis, wide metaphysis, bowing of diaphysis, and blurring of the trabeculae are characteristics of rickets. Osteomalacia is characterized by presence of persistent excessive osteoid, and the contour of the bone is not affected. However, the bones are weak and are susceptible to the fracture. The clinical features are vague bony pains, muscle weakness, fractures following minor injuries, grain stick fractures, or looser zones. On radiology, looser zones, codfish vertebrae, and trefoil pelvis are characteristics of this osteomalacia. For the biochemical changes in the rickets and osteomalacia, the serum calcium level is now usually normal, or it can be decreased. The serum phosphate levels are also decreased, but the serum alkaline phosphate is increased due to osteoblastic activity. The product of serum calcium and phosphate is decreased. Normally it is 30. In rickets and osteomalacia it is less than 24. Hyperparathyroidism results in bone resorption. It is primary if resulted from an autonomous hyperplasia or adenoma, or secondary to prolonged state of hypocalcemia. It results in three interrelated morphological alterations, that are osteoporosis, brown tumor, or osteoitis fibrosing cystica. Osteoporosis is generalized and affecting cortical bone more severely, and osteoclast form characteristic railroad tracks. Bone loss and microfracture result in vascularity, hemorrhage, and hemocyte deposition. The severe form is von Recklinghausen disease of the bone, and it is the combination of increased bone cell activity, fibrosis around the trabeculae, and cyst formation. In this radiograph, you can see bulbous swellings and numerous cavities of the small bones of the head, and these are giving clue to the bone resorption. Then the disease is associated with metabolic pathways, enzymes, ion channels, and transporters. And the important member of that group was osteopetrosis, and we discussed various autosomal dominant and autosomal recessive, and one X-linked this osteopetrosis also. Then disease is associated with bone mass, osteoclast dysfunction. Renal osteodystrophy is the morphological alteration in the bone in chronic renal disease. These are manifested as decreased bone mass, impaired mineralization of the bone, hyperparathyroidism, or growth retardation. The histological bone changes in end-stage renal disease can be high turnover bone disease, low turnover or adynamic disease, or mixed pattern disease. In high turnover osteodystrophy, the resorption of the bone predominates, while the low turnover or aplastic is adynamic, while the mixed pattern, in mixed pattern you can see both the high turnover and low turnover areas. This picture is showing manifestation, the pathogenesis of manifestation of chronic renal disease, and what happens when there is decreased renal phosphate excretion. There is hyperphosphatemia, and this hyperphosphatemia will lead to decreased serum calcium. When the serum calcium is decreased, that is sensed by parathyroid hormone and result in hyperparathyroidism, and it leads to osteoitis fibrosa cystica, or in the secondary hyperparathyroidism. On the other hand, hyperphosphatemia will result in increased product of calcium and phosphate, which goes above 70 and results in metastatic calcification. Metabolic acidosis leads to osteoporosis. Then decreased conversion of the cholecalciferol into its active part is decreased in chronic renal failure, and when this is decreased, there is decreased absorption of the calcium from the intestine on the one hand, and on the other hand there is aluminum intoxication, and this aluminum comes from usually from the dialysis fluid, and all this result into osteomalacia.